afternoon, everyone, and welcome to today's Public Health Ontario Rounds. Our presentation today is in honor of World Tuberculosis or TB Day 2022, and it will focus on what's new with latent TB infection diagnosis and management in the updated Canadian TB standards, which have just been released. My name is Leanne McDonald. I am a public health physician here at PHO, and I have the pleasure of being the moderator for today's session. And I have a few housekeeping items just before we get going. So the chat pod has been disabled to limit any distractions during the presentation, but please do use the Q&A pod if you have questions during the session. And the presentation will be followed by a discussion and a Q&A period. If at any point during the session you have any technical issues, please email capacitybuilding@oahpp.ca. And I would like to declare on behalf of myself as the moderator of the session, I don't have any potential conflicts of interest to declare. I am employed at PHO and participating on some CHR funded TB grants, but no conflicts. Before I introduce our wonderful speakers for today, I wanted to begin with an Indigenous land acknowledgement. I would like to acknowledge the land on which we are gathered and reflect on our accountability to continuing to learn from and build meaningful relationships with Indigenous people. We acknowledge that the land that we are hosting this virtual event on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. It's now my pleasure to introduce our speakers for today's presentation. So that's Dr. Gonzalo Alvarez and Andrea Saunders. And we are also very fortunate that Dr. Elizabeth Ray will be joining us for the discussion Q&A portion of today's session. Dr. Alvarez is an associate professor of medicine at the University of Ottawa and scientist at the Ottawa Hospital Research Institute. In addition to work serving the Ottawa region as a respirologist at the Ottawa Hospital, he is also a respirology and tuberculosis consultant for the Nunavut Department of Public Health and does clinical work in multiple places. Dr. Alvarez is the associate editor of the newly updated Canadian TB Standards 8th edition. We're delighted to have him. We are also very delighted to welcome Andrea Saunders, a communicable diseases specialist with PHO's Health Protection Department today. She is a nurse epidemiologist, and her work encompasses a variety of activities related to public health surveillance and management of infectious diseases, with an emphasis on TB, influenza, and emerging respiratory pathogens, as well as STIs and BBIs. Andrea is a graduate of the Canadian Field Epidemiology program and has also completed postgraduate training in tropical nursing and public health at the London School of Hygiene and Tropical Medicine. And finally, Dr. Elizabeth Ray has been the Associate Medical Officer of Health with the TB program at Toronto Public Health since 2005. She's the lead author of one of the chapters of the updated TB standards, the Contact Follow-up and Outbreak Management chapter, and co-chair of Stop TB Canada. She has served as the chair in the past of the now sunsetted PIDAC CD Tuberculosis Working Group, as well as leadership on a number of other TB work groups. She's also an adjunct professor at the Dalla Lana School of Public Health, University of Toronto, where her teaching has included communicable disease control, epidemiology, and public health ethics. So thank you so much to Gonzalo, Andrea, and Elizabeth for being with us today. And over to you, Andrea, to lead us off.
Thanks, Leanne. So just before we get started with today, I will begin by stating that neither Gonzalo nor myself have a conflict of interest to disclose. Neither of us also have received financial support or any in-kind support from a commercial sponsor. We do have a few learning objectives for today's session. So by the end of today's presentation, we hope that you will be able to describe the provincial epidemiological trends for both active TB disease and latent TB infection reported in Ontario for the period of 2012 to 2021. We also hope that you'll be able to identify 3 evidence-informed changes to the Canadian Tuberculosis Standards, 8th edition's recommendations for LTBI diagnosis and treatment, as well as to be able to consider potential implications of the updated LTBI diagnosis and treatment recommendations for public health practice and primary care. So if we begin by taking a look at the epidemiology of active TB disease in Ontario over the last 10 years, we can see that since 2012, the incidence of active TB disease has somewhat plateaued, with between 600 and 700 cases being reported each year, which corresponds to an incidence rate of between 4 and 5 cases per 100,000 population. We did observe a slight increase in cases in 2019 when we had almost 750 cases of active disease reported, and the incidence rate surpassed 5 cases per 100,000 population. However, this was followed by a slight decrease in both the number and rate of reported cases of active disease in both 2020 and 2021. However, without further investigation, it is unclear of the extent to which the COVID-19 pandemic may have impacted TB case detection in the province, and consequently, if this decrease that we're observing in reported cases reflects a true decrease or plateauing of cases, or rather an underdetection of active disease. When we look at the distribution of active TB cases by age and sex for 2021, we know that males accounted for just over half of all active TB cases in the province. In 2021, we observed a peak of incidence in those aged 20 to 29 years of age for both sexes. Then we see the incidence rates begin to drop off over the next few age groups, and then we start to see an increase again as we go up to those 60 to 69 and 70 to 70 plus years of age. And here we see that there's a little bit of a broadening between the incidence rates of males compared to females. If we look at where in the province our active TB cases are being reported, we see that the health units for the City of Toronto and the region of Peel both reported the highest incidence rates in the province for 2021, with between 8 to 9 cases of active TB disease reported per 100,000 population. These two health units, along with the City of Ottawa and the region of York public health units, accounted for almost 80% of all active TB cases in Ontario in 2021. Of note, in the past 5 years, there are actually 3 health units that have not reported any active TB cases, and a further 9 public health units that have reported fewer than 5 cases per year over the last 5 years. The origin of TB cases in Ontario between 2017 and 2021, we see that almost 85% of all of our TB cases were born outside of Canada. Almost 7% of cases were born in Canada, and of these, less than 1/3 were reported among those belonging to First Nations, Inuit, or Métis communities. Individuals from just 5 countries, India, Philippines, China, Vietnam, and Pakistan, accounted for close to 2/3 of all cases among those born outside of Canada. The origin of active TB cases in Ontario varies significantly depending on where you are in the province. For example, in the Greater Toronto area, which encompasses the health units of Toronto, Peel, and York, close to 90% of all cases are diagnosed among those born outside of Canada. Whereas in the 3 largest health units in Northern Ontario, Northwestern, Thunder Bay, and Porcupine health units, approximately 70% of all cases are reported among Indigenous Canadians. And this highlights the need for different regional approaches to TB prevention and care in Ontario. When we think about drug resistance, and for those of you who may be less familiar with treatment regimens for active TB disease, there are 4 antibiotics that are used as first-line treatment, and these include isoniazid, rifampin, pyrazinamide, and ethambutol. Monoresistance is defined as resistance to one first-line anti-TB drug only. And you can see that between 2017 and 2020, we had approximately 50 to 75 cases with monoresistance reported each year. Polyresistance is resistance to one or more first-line drugs other than both isoniazid and rifampin. And this was much less commonly reported over the last few years. Multi-drug resistant TB occurs once you have resistance to both isoniazid and rifampin and other drugs, and we only have a handful of cases reported, fewer than 15 identified each year over the last 4 years. And finally, extensively drug-resistant TB, which is resistance to isoniazid and rifampin, a fluoroquinolone, and a host of other drugs, including amikacin, capreomycin, or kanamycin, or bedaquiline or linezolid, a few of the newer drugs for TB treatment. And fortunately, you can see that in Ontario, we have had no cases of extensively drug-resistant TB reported in the last 4 or 5 years. When we look at the number of reported latent TB infections in Ontario over the last 10 years, we do see that there is a gradual decrease in the number of LTBI infections reported between 2012 and 2019. And then, as you can see, in both 2020 and 2021, there is a very sharp decrease of cases reported in Ontario. This decrease is close to 50%. But as mentioned earlier, as with active TB disease, the impact of the COVID-19 pandemic on individual health-seeking behaviors, access and availability to healthcare, and other factors such as public health follow-up and data entry need to be more fulsomely examined in order to better understand the true burden of LTBI in the province. So while the rates have decreased, we're also a little unsure about whether or not this reflects the true burden of latent TB infection or likely some of the impacts of the COVID-19 pandemic. When we look at the distribution of latent TB infections by age and sex for 2021, we do see that the age groups 20 to 29 and 30 to 39 bear the burden of LTBI in the province, with the majority of cases occurring within this age group. And as you can see, the incidence of latent TB infection is much higher in the female population than it is for males. And this trend could partially be explained by the number of LTBI screening requirements that are in place for many employers and educational and training programs in both the healthcare and childcare sectors that engage a higher proportion of females. And finally, when we look at the geographical distribution of latent TB infection for the year 2021, we do see that the city of Ottawa and the region of Peel Public Health Units accounted for almost 1/3 of all LTBI notifications in the province in 2021. However, the highest rates were observed in the Middlesex London Health Unit with 56.4 LTBI infections per 100,000 population, followed by Ottawa, Waterloo, and Hamilton. And that summarizes the overview of the epidemiology of active TB and LTBI in Ontario. And I'd like to part with saying, as we gradually begin to transition to thinking about public health priorities in the wake of the COVID-19 pandemic, it is apparent that active TB disease and latent TB infection warrant much further attention. And with that, I will hand things over to Dr. Alvarez to walk us through the recently updated recommendations on LTBI diagnosis and treatment.
Good afternoon, everyone. Thank you very much for inviting me to talk at these rounds. I must say I'm floored at the number of people who have joined us this noontime. It's wonderful, over 400 people. So I'm happy to be here to be able to present on the Canadian Tuberculosis Standards, the 8th edition. I will say that the first edition was actually published in 1972. So this has been a long-standing Canadian tradition. And it's fantastic to be here to talk, and also to thank the organizers, Dr. McDonald as the moderator, and also my co-presenter, Andrea Saunders. So just to start off, this new online publication that was published in the Canadian Journal of Respiratory Critical Care and Sleep Medicine just came online last week, so it's fresh off the press. It's the 8th edition of the Canadian TB Standards. You will have a link so that you can get to all of these articles, and I hope that you do get to reading them, because obviously I'm only going to be able to give you an overview in these next kind of 30 minutes. so that then we can take some questions at the end. And I wanted to thank the editor-in-chief, Dick Menzies, who did an enormous amount of work to be able to put this huge set of guidelines together. There's actually 15 articles, so there is a lot to read, and also to all the other associate editors, including Christina Greenaway, James Johnston, Richard Long, Howard New, and Tom Wong. And the list is even longer, just so that you can see a real long list of TB experts in Canada. So wonderful to see this many people involved in putting together the evidence base. So before we get started, just a couple of disclosures. I'm just going to move this here. I do not hold any financial associations with Sanofi, the makers of rifapentine. I also do not hold any financial associations with any of the generic companies making rifapentine or the fixed dose combination product. I have received funding from the Public Health Agency of Canada to do investigator-driven studies of 3-HP in Canada. And rifapentine is not Health Canada approved, but has been available in Canada through the Urgent Public Health Needs Regulation. So let's start off with the diagnosis of TB infection, and then I'll go on to the treatment of tuberculosis infection. So I'd like to thank the authors, Jonathan Campbell, Chris Pease, Peter Daly, Madhu Pai, and Dick Menzies for putting together this article. So the first and most important recommendation in regards to an overview of the new changes is the first thing is to say that testing for TB infection is not recommended in the following situations. So if people are low risk or have a low risk of progressing to TB disease, then it is not a good idea to be testing these folks. Also, if you're looking to diagnose active TB disease in adults or adolescents over the age of 12, this is another place where it would not be recommended to do testing. Testing is also not recommended for routine mass screening. There are exceptions, of course, to this in terms of contact investigations or occupational screening programs, but I call these focused screening programs as opposed to just routinely mass screening. And also, testing for TB infection is not recommended for monitoring of response to TB disease treatment. So there's just a couple of situations where testing for TB infection would not be recommended. Second recommendation is that both the tuberculin skin test, and which I'll from here going forward, I'll call it the TST, and the immune gamma release assay, going forward, I will call it IGRA. Tests they're acceptable alternatives for TB infection diagnosis. You can use one or the other, and I'll give some examples in terms of when you might use one and then the other. But either test can be used for TB infection screening in any of the situations in which testing is indicated. What we've seen, I think, in the last 10 years since the last standards, or 2014 since the last standards, is that there's been significantly more use and more use of the interferon gamma release assay, or the IGRA. And in fact, to keep it simple, you can pretty much use IGRA in all situations. I would say with the caveat of when you start getting into young children under the ages of 5 or even under the ages of 2, the evidence is not as strong, but nonetheless did receive conditional recommendations by the pediatric group. So I would encourage all of you to read the chapter 9, which is the pediatric section, if you really wanted to get into the specifics for children in these ranges. But for the most part, you can use IGRA in any situation. And in particular, the people who have been BCG vaccinated. The key thing about the interferon gamma release assay, of course, is that it has a high specificity, or it has a greater specificity than the TST, because it can differentiate between BCG and no BCG. And that obviously has a strong impact in a lot of the people that we treat for latent TB infection. As Andrea mentioned, the foreign-born populations constitute a large number of people who develop active TB disease, and also constitute a large number of people who have been BCG vaccinated. So there's certainly that group where you can consider using IGRA. and therefore be able to increase the specificity of the test used. The other advantages of IGRA, of course, are the fact that it's a lab test, so no one has to really be trained to use it. And what's interesting with that is that as time goes on, we have less and less people that are actually trained to be able to administer the TST. And I think that's an important point as time goes on, whereas the IGRA is a lab test, blood test that is sent to the lab, and then the testing is done there. The other thing is for the TST, as most of you will know, you have to come back usually for whereas with the IGRA, you don't have to do that because it's just a lab test. And so those are just a couple of the key differences and importance. Now, I did mention that you could use IGRA in pretty much all situations except for this. And the TST is still the preferred test when doing serial testing. And serial testing is really when you are doing tests in order to look for conversions. And this we usually see in either healthcare or other populations like corrections staff or prison inmates. And it's when you're going to be doing repeated testing. And the reason for this is that the TST has been around for 100 years, and there are clear conversions and measured conversions, usually 6 millimeters, that allow us to determine whether someone over time has been exposed after having a baseline test. And this threshold has not been developed yet for IGRAs. And so what constitutes a real conversion with IGRA is still unknown. And that is why we continue to recommend using the TST as the preferred test when doing serial testing. The next recommendation in terms of, again, as an overview, both TB infection diagnostic tests may be used sequentially in the following situations. So the first one would be if you start with either a TST or an IGRA and you get a negative test, but the patient that you have in front of you is high risk for infection or high risk for the progression of TB disease, and therefore the risk for a poor outcome is high. And so that can be encapsulated in saying that you have a high pretest probability. What you could do is do a second test in order to increase the sensitivity of the diagnostic tests. So if you had a high pretest probability negative TST, you could go on to do an IGRA, and if it were positive, you may consider treatment. Conversely, the same can be said if you have a low pretest probability, that is someone with a low likelihood of infection or a low likelihood to go on to have active TB disease, or of course, has a high risk of a false positive result due to BCG. So if you were to have an initial TST that is positive and you want to increase the specificity, the use of an IGRA would also be recommended in this situation. And another concept that I'd like to put forward to you is that of risk stratification for progression to TB disease among people who are TST or IGRA positive. And this is a great little table put together by the authors that basically shows you the risk factors. Because remember, before we said we're not saying to folks to go out and do a routine mass screening, but we want to look at people who may be at high risk. And of course, we know that people living with HIV are far and away the folks that have the highest annual risk of TB disease. And what's important to note is that the annual risk of TB disease is the highest in the first 2 or 3 years. In fact, some of the studies even demonstrate that perhaps even 50% of the lifetime risk is within those first 2 years. So after those 2 or 3 years, the risk does decrease. It's not zero, but it does decrease over time. Also, this is a spectrum of risk that's being shown here. And so you can see that at the very top is HIV, and at the very bottom, you can see folks with no other risk factors. And some highlights that I'd just like to mention: transplant recipients, people receiving immunosuppressive drugs like TNF-alpha inhibitors or steroids, and people who smoke, for example, at least a pack of cigarettes a day, do have an increased risk of developing active TB disease if they have a positive TB skin test. Just before I go on to the preventative treatment, I'll just say that in general, the positive predictive value of any TB infection, diagnostic test that is, for progression in TB disease is low. And we definitely need more research, and there is. It's a very hot topic around the world in terms of looking at better biomarkers, things that are easier to do around the world in order to really be able to predict active TB with greater accuracy. Because to be honest, the positive predictive value, again, is not great with both the TST and IGRA. But as already mentioned, the TST has been around for 100 years. We are now expanding and shifting more to use of IGRA. And IGRA does add more specificity to the testing. Also very important, my last point on this section is that the IGRA is not covered by the Ontario provincial government, and that does cause issues in regards to its operations and also to its access. We hope this will change in the future, and if there is, in this large group of interested people, anyone who is in that domain that could help us get this this test funded by the provincial government, it would be fantastic. So moving along to tuberculosis preventative treatment of adults. The World Health Organization, in fact, uses the term TPT, which is kind of new and I think is a lot more reflective than LTBI treatment, in that it really is tuberculosis preventive, right? Focusing on the preventive aspect of treatment. I'd like to thank my co-authors on this guideline, Christopher Pease and Dick Menzies. So what are the major changes from the last Canadian TB standards in 2014? Well, in 2014, the standard of care for the treatment of latent TB infection, or TPT, was 9 months of daily isoniazid. So there's been some tectonic shifts and a lot of research done since then that has then resulted in this new change, or this new guideline or recommendation, that the new first-line regimens in Canada that are recommended are either once weekly rifampicin and isoniazid for 3 months, or daily rifampicin for 4 months. And it should be noted that these are both rifamycin-based regimens, and if they cannot be used or cannot be tolerated or are not feasible or contraindicated, the 9 months daily isoniazid regimen is the preferred alternative option. But again, the key is that these two, 3HP and 4R, I'm going to use now going forward, are the new first-line regimens, and 9H is now delegated to the alternative option. Not recommended for routine use, 3 months of daily INH and rifampicin because of toxicity of INH and drug interactions of RIF. 9 months of twice weekly INH is used, directly observed in some parts of Canada. There's very little evidence for this, and we do believe that 3HP is a better option in that situation. So it's still used, but not recommended for routine use. And at the end of the presentation, I'll just talk a little bit about what's coming up, because there really is a bright future in this, and that the lower that we can get and the shorter that we can get in terms of treatment, we know that we can get better outcomes. And there's this 1 month of daily INH and rifampicin called 1HP. The evidence right now was published in the New England Journal about a year ago, and it was done primarily on HIV positive patients. Therefore, for non-HIV infected patients, there's not enough evidence as of yet, and therefore we could not make a strong recommendation for 1HP. But we do know that there is an ongoing trial for non-infected or non-HIV, for the non-HIV population, that we hope to see in the coming years. The key things to consider with these new regimens: first and foremost, that all rifamycin-based regimens have important drug-drug interactions. So this is what I really want to kind of underline for the folks on this call. So if you are considering putting your patient on either 4R or 3HP, that you really should be thinking about interactions with other drugs. And what these rifamycins do is they're potent inducers of hepatic metabolizing enzymes, specifically the cytochrome P450 enzyme, which can result in increased elimination of other medications. A good example of this, for example, is the oral contraceptive pill. So that if a woman is on the oral contraceptive pill and starts on one of these regimens, either 4R or 3HP, the oral contraceptive pills' efficacy can drop. Therefore, a very important thing to review with your patient and consider what alternatives one has in the different scenarios. And that's why we recommend that people use an up-to-date drug decision support tool to look at drug-drug interactions or to speak to your local pharmacists in order to get more information on that. So to summarize, and of course I could spend an hour talking about 3HP and 4R by themselves, but in a snapshot overview, 3HP, there is excellent efficacy and completion rates. In fact, some of the post-marketing, some of the largest post-marketing studies done in the US show up to 87% completion of those who started. The benefit, of course, of 3HP is that it's only one dose once a week, and in 12 weeks, you're done, which you can imagine compared to 270 doses of daily isoniazid has been really a game changer in the way that we're able to prevent this disease. Generally, all doses should be directly observed. This is an important point. I will say that there is now movement both well, in Toronto and in Ottawa with the pandemic. One of the silver linings of the pandemic has been that we've moved a lot more to virtual. So we're hoping to roll out virtual directly observed or treatment support for 3HP. And also that in other parts of the world, including the CDC and the World Health Organization, they do mention that self-administered is also acceptable. Of course, in the questions I could answer more about this if there are questions about that. The other key thing about 3HP, and you'll notice as well with 4R, is that there are significantly lower rates of liver toxicity compared to isoniazid. And this is a really big step because the biggest problem that we had with isoniazid is that the older people got, there was an increased risk of hepatotoxicity. And in fact, there are many people who died from taking INH prophylaxis over the years. And this is really important to note that these two regimens have a much lower rate of liver toxicity and hence makes it a lot easier to be able to apply. Potential disadvantages, the most common side effect is a flu-like reaction that is short-lived and mild. It's usually a grade 1. Could sometimes be a couple of hours. People normally can then just continue on their day. There is rare hypersensitivity reactions that can occur, again, quite rare. And again, I'm going to highlight the biggest issue, which is the drug-drug interactions, which are really important, and they're seen in both of these rifamycin-based treatments. For 3HP, though, there's also the issue of high pill burden. There's about 10 pills currently that people take once. That's for a 75-kilo person. And lower, obviously, the lighter or the less weight the person weighs. But I will tell you that there is now a generic that is actually being produced by a company called McLeod's, where they are producing a new fixed dose that is 3 pills. So it would be 3 pills once a week for 12 weeks. And we're hoping to be able to access that very soon in Canada. Now, the summary for 4R, also excellent efficacy and completion. In fact, there was, I'll just mention that going back to 3HP, for 3HP, the landmark study was published in 2011 in the New England Journal of Medicine by Sterling and Company. And the 4R was also published in the New England Journal of Medicine in 2018 by Dr. Dick Menzies. And it was a fantastic international study with 3,000 or 4,000 patients in each arm. And completion rates ranged anywhere between 75 and 80%. They were fully self-administered treatments. They were tested in high and low middle income settings. There's about 120 doses that are given daily over 4 months, which again is a significant decrease from what we were using with 9H. And we also see very low rates of liver toxicity compared to 9H. Some potential disadvantages, compared to 3HP, there's a longer duration and greater number of doses, some risk of allergy in terms of rash, and again, highlighting the key thing that I want to make sure folks that are going to use these two regimens are the drug-drug interactions, which are important. Most important, I think, is kind of the general statement that both 3HP and 4R are considered equivalent in terms of safety and efficacy, given that both of them in those two New England papers that I talked about, both of them have done randomized controlled trials compared to the standard of care at that time, which was 9H, but they have obviously not been compared directly. So the choice should be tailored to the specific circumstance that you find yourself in and your patient, considering factors such as patient preference, pill burden, number of doses, potential for adverse events, and cost. The other issue to consider is healthcare resources and capacity to ensure completion of treatment is quite important as well. So when we think about those things, I wanted to share with you some evidence for Ontario that would be specific for the people on this call, and that was published just this past January. And it was a paper that my group put out, where we looked at the effect of the implementation of 3HP in addition to 4R and 9H to prevent TB on completion rates. And we used an interrupted time series designed to do this. And so what we really aim to do again is to offer 3HP in this regional clinic where we were offering 9H and 4R. So we added it as an alternative. And then we wanted to see if by adding it, could we increase the overall proportion of patients that were completing a TB preventative treatment, otherwise known as TBT, above the baseline rate. So what did we find? Well, this is a figure that shows here the completion rate on the y-axis, the percent of patients that completed who had started or at least taken one dose. And we looked at our data back to 2010, and these are quarterly increments here of patient completion logs. And you can see that we followed them up until 2016. There was about 3,000 people that were included in this part of the study. And then we introduced, and then you can see that this was the baseline rate of completions that we had. And then in around 2016, Health Canada had not approved 3HP yet. So we got Health Canada approval to do this study as a phase 3. And we were able to introduce it in our clinic over a period of 2 or 3 years. And so at this point here, where this line is here, you can see this is where it was introduced, and nothing else was changed from the program. And we were able to get 89.7 completion of those that started 3HP, which actually mimicked the post-marketing data coming out of the US, where the rates were around 87, 88% completion of those who started. And when we looked to see how that affected our program, by adding 3HP as an alternative, we were able to increase the absolute completion rate of all comers by 19%. And so we really felt like it had a really positive impact to our clinic. And this gives you an example as to what real case, real world scenario of what happens in Ontario. Well, what about a summary of isoniazid? Remember that isoniazid has been shown to be effective, and in fact was the standard of care prior to these guidelines. People often ask, the difference between 6, 9, and 12 months. In fact, the original landmark studies were actually 6 months, and then they did some that were 12 months. And way back in the day, they picked 9 months because that was really where there was a plateau in terms of the number of completions, because the longer, obviously, that you go with these preventative therapies, the less people are able to complete. But the key thing to remember is that INH liver toxicity is common, and it is related to older age, and it is, after the age of 35, you can see an incremental risk of hepatotoxicity every decade that we go forward, and also related to comorbidities. And that INH toxicity may be undetected in routine practice, especially because it had been routine for so many years that much of it kind of may have gone undetected. So that's all I'll say about INH. And now some special populations. So contacts of a drug-resistant TB case So the recommendation that we made, and we called it poor evidence, meaning that the RCTs are ongoing, and that's what's really important and exciting, is that there are ongoing studies for this. But for contacts of an index TB case with MDR-TB, and by definition, MDR-TB is when a patient has a TB isolate that is resistant to both rifampin and isoniazid, we recommend either levofloxacin or moxifloxacin for 6 to 9 months. And that is, of course, assuming that the source case or isolate is fluoroquinolone sensitive. So again, there are ongoing studies. We hope that they will be reported soon in the coming years. But for now, this is the recommendation for people exposed to MDR-TB. If the other point that I should make is that all patients with latent TB infection who are contacts of a person with MDR-TB should be followed for 2 years to ensure that they do not develop disease. We call this a good practice statement, which is otherwise an expert opinion, where there is no evidence, but we do believe that this is a prudent thing to do to ensure that we do not see an increase in MDR-TB cases, which in fact are usually in Ontario single digits, as Andrea noted in the previous presentation. So what if we look at patients or persons being treated for organ transplant or HIV infection? So transplant patients should receive latent TB infection testing and treatment, and if positive, if positive, they should be treated. And we should do this prior to transplantation. So that's quite important, right? That all folks that are going for transplant that are going to be immunosuppressed should receive a latent TB infection testing, and if positive, should be treated. Now, alternatively, if, for example, a patient that is on or that has a transplant gets exposed to tuberculosis and tests positive, the treatment should be 9 months of isoniazid. The reason why we suggest this is because the risk of using a rifamycin containing regimen in the context of a transplant where rejection medications are of paramount importance is central. So due to the risks of rejection because of a rifamycin based TPT or TB treatment, TB preventative treatment, I would not recommend the use of the rifamycins in this case. All right. In regards to pregnant and breastfeeding patients, I would say that in pregnant patients, we suggest that TB preventative treatment should generally be deferred until after delivery, unless the risk of reactivation is very high. And I think that this is an important point. I will also say that although there have been pharmacokinetic studies done for 3HP, and there is ongoing studies currently looking at 3HP being used in pregnancy, the authors of this recommendations felt that 3HP should generally be avoided during pregnancy and in breastfeeding mothers until more data are available. And in my last, or just second last slide, I really wanted to say that the future looks really bright in regards to TPT or TB preventative treatments, and shorter regimens are right around the corner. As I previously said, the 1HP, which is basically rifapentine and isoniazid once daily for 4 weeks, is really a pretty significant drop in how long one would need to take. And I think we're really excited to see the non-HIV population trial, which, like I said, is currently being run. And we're hoping that we will get information soon on this and that will be kind of in the next corner. But also other regimens that are on the horizon include 6 weeks of daily rifapentine, otherwise known as the asteroid trial, and also 8 weeks of high dose rifampin for 2 months, called the 2R2 trial. So we're looking forward to seeing all of these things. And I will say that without a doubt, I'm excited about seeing shorter regimens because, for example, our group, we did do a network meta-analysis showing that the shorter a regimen is, the higher the rates of completion. And I think that's really important. And who knows? I mean, the dream would be to be able to see something like 1 week treatment, or even just a couple of days of treatment that could do, because that would obviously be a planetary game changer, and we hope that will be the future. So I wanted to again thank all the authors of the TB standards, and here they are all on a Zoom call in putting these together. And I'd like to thank all of them for all of their input.
Thank you so much, Andrea and Gonzalo, for those very insightful presentations, and for the positive outlook, Gonzalo, on the future and thinking about the studies that are underway. I want to welcome Dr. Elizabeth Ray joining our Q&A discussion panel here. And I will start by just working my way through some of the questions, and as I read them out loud, the audience will be able to see them. And I just do want to note, it's fantastic to see so many people who have joined. Over 400 have stayed through to this point, which is wonderful engagement. There was a administrative question about whether a recording would be made available to attendees. So a presentation, slides, and a recording will be made available about 2 weeks after the live session, given speaker consent, whatever the speakers are able to consent to providing. So with that, I'll maybe move into a question that I believe will maybe offer Andrea the opportunity to answer first, which was about interpreting some of the trends around the LTBI notification. So from Durham College asks, have you considered the decrease in reporting and whether it's directly related to a decrease in international students in post-secondary schools since 2019? Over to you, Andrea, and others feel free to comment.
Thanks, Leanne. Yes, Bev, that's a fantastic question and a great observation that yes, the decrease in international students and other visitors to Canada, either on a temporary or permanent residence, there was some barriers to arrival in Canada during the pandemic years. So yes, that is a very likely explanation for some of the decreases in our latent TB infection notifications and possibly even some of our active case detections, given the proportion of our cases that are diagnosed among those born outside of Canada. And as I mentioned, we'll be doing some further investigation to try to identify, there's likely a multitude of factors related to the pandemic that have impacted TB prevention and care in Ontario. So we'll be further analyzing our data and doing some further investigations to try to better understand and describe what happened in Ontario over the last few years.
Thanks, Andrea. Do others want to comment? We can move on. We have lots of questions.
Yeah, I think, well, I'll just chime in. I totally agree with Andrea. And I mean, certainly Drs. Sarah Broad and Faz Khan did show that, during the pandemic, just like what we've seen around the world, there has been a decrease in diagnosis of TB itself. And that's a trend that we've seen around the world. So, another thing that I think is probably reflective in Canada, but to what extent we'll have to see in the coming year or years, to be honest.
Thank you. Okay, so we have a few questions about IGRAs that I believe Gonzalo already addressed either in his comments or Elizabeth in the chat, but there was one quite specific question about if someone is TST positive and they are BCG vaccinated, and that may be affecting interpretation of TST, but they do need serial testing. So for example, due to continuous exposure, is it recommended to do repeat testing with IGRA in that particular context? Gonzalo, do you want to maybe address that one?
Yeah, that's a great question. I mean, as much as what I want to do with these guidelines, and especially with these kinds of presentations, is that we want to give you guys pragmatic, operational type recommendations. And I would say that, with the IGRA, one should not be using IGRA in serial testing. And the reason, actually, the threshold for a conversion is very hard to ask, or at the moment is hard to ascertain, and they haven't figured out exactly how much of a change in the level of interferon would constitute a conversion. The other point would be that, once you're positive, there's really no point in repeating tests going forward, because we consider that a positive going forward for life. And there isn't really any other test, because I often get the question, and that is, of if I was TST positive or IGRA positive, and then I get exposed later on, what test would you suggest? And in fact, there is no good test to do that, because it's an immune. The tests that we have right now are in fact immune-related tests, and it's like a memory. That's the only way that I try to explain it for you. We can't erase the memory; it's always there.
Just to add one thing to that, this issue about how should we manage serial testing. Put a comment in the chat or the Q&A, which is a really important piece, that we're actually trying to move away from serial testing, even for most healthcare workers who've been kind of like one of the traditional mainstays of getting an annual TST. And that's because in North America anyway, for the majority of healthcare workers, there are going to be some groups that have much higher TB exposures, but for the majority, the conversion rate is so low that the opportunity cost of doing all of those annual skin testing, or trying to do it, really just is not worth. You just don't find enough conversion. So that whole issue of serial testing hopefully will shrink to a much more manageable group of people. So the question even won't apply.
And if I might, another thing that I might add to that exactly is, because there's a couple of questions there about, sorry, Leanne, just to note, but I did mention the fact that people are asking whether IGRA is covered by OHIP, and it is not. In fact, in Ottawa, I don't know how much it costs in Toronto, but in Ottawa, it's close to $100.
Yeah, same.
And that is a direct cost for the patient. And we're hoping that it'll become publicly funded. And if there's anyone, out of you 400 people on this call that's involved in that and want to help us, it's certainly something that would definitely be something going forward into the future.
So I'm just to emphasize that point, like, the more people ask, the more we're likely to get some movement on that. The PIDAC TB work group, which was sunsetted, but before it was sunsetted, had done a whole bunch of work developing sort of rationale document and starting to talk with the Ministry of Health about getting IGRAs funded. And then the pandemic happened. So that's absolutely something that we, like all of us, need to kind of collectively pick up that work again.
Thanks. We do have a few more questions. I'll try and group some of them so we get to as many as possible in the next few minutes. We had a few questions related to 3HP. So one was a basic, what does the acronym stand for? Why do we say 3HP? And then a couple of questions about cost. So one, 3HP versus 9 months of INH, or 3HP versus 4 months of rifampin. So maybe Gonzalo, you want to start off and others can comment?
Yep. So first of all, I don't know who makes those shortened things. It's just it's what's used around the world. So H stands for for the INH, and rifapentine. I think the P rifapentine, but that's just what is used around the world. So that'd be the first thing. In terms of cost, cost is a little bit of a thing to be studied. We've certainly done cost effectiveness studies. We've just completed one in Ottawa. We hope to publish in the next month. So be on the lookout for that. We did publish a cost effectiveness study up in Nunavut. it does, the 3-HP is around $100 to $120 for the whole treatment. And I believe that INH is probably a tenth of that, 10% of that, or maybe 20% of that. And then it all depends as well. The reason why I say it depends is the same with like 4R, for example, in terms of its costs. It does depend on the dispensing fees. So there is kind of variability in different parts of the province, but I'll just say that the top end, the top cost would be at around $120. But what we've noticed in terms of cost effectiveness analysis that we published up in Nunavut, like I said, that it was cost effective even when adding in the extra costs of directly observed therapy. And we've seen the same thing in a separate study, like I said, that we hope to publish in the coming months in Ottawa.
And just from a public health program point of view, I want to really emphasize that part. Like, there was no point in us spinning our programmatic wheels, you know, saying we're talking about TB elimination, tossing out regimens that don't get completed and don't accomplish the task. So, you know, it's way better to put the effort, and even if it's, you know, $120 versus, you know, a smaller amount for INH, if the INH isn't accomplishing that much, you know, as programs, we need to think about what are we actually accomplishing.
But I always must admit, I mean, especially when I'm talking with my health economists colleagues and co-authors, it's complex, right? So
Yeah.
But what I would say is that there's a lot of variables and everything, and I would urge you to take a look at some of those cost effectiveness papers. But at least you get an idea or a ballpark of what it costs, because it is specific to the place that you're rolling out your program.
Thank you so much. I am going to acknowledge that there are some more questions on 3HP and 4R that we won't have time to get to in detail, but for those that missed it at the beginning of the presentation, the new updated Canadian TB Standards 8th edition are published online. I believe the link is sort of up in the chat. We can try to re-up that, but you can certainly search for it and find it. And I'd really encourage everyone who's interested in learning more and learning more about the evidence referenced to inform the recommendations to go to the source. With that, I want to thank everyone for today's session. I want to thank Gonzalo Alvarez, Andrea Saunders for presenting, for Elizabeth Ray for joining in the discussion and question period, and all of you for spending your time over the lunch hour with us on today's session. Excellent virtual participation, and we know it continues to be a busy time. You will receive a brief and anonymous PHO Rounds survey following today's session. Please try to complete this. We use it to help us improve our programming. And lastly, to access previous PHO Rounds presentations and view upcoming sessions, you can visit the PHO website, head to Education and Events, and click on the presentations. So thank you. Have a wonderful day. Sorry we couldn't get to all of the excellent questions, but look forward to more discussions on TB to come.